Hi, this is Dr. Pedro Ramirez, editor-in-chief of the International Journal of Gynecological Cancer. And today I have the great pleasure of welcoming back to our podcast our dear friend and colleague, Dr. Brad Monk. He's at the Florida Cancer Specialists and Research Institute in West Palm Beach, Florida. And the topic of this discussion is the recent publication in Annals of Oncology titled Ultrasensitive Detection and Tracking of Circulating Tumor DNA to predict relapse and survival in patients with locally advanced cervical cancer, phase 3 CALLA trial analysis. Brad, thank you again for your time. Thank you for accepting our invitation, and always great to see you. Looking forward to this discussion.
And thank you, Pedro. And I want to thank you and your staff. Arguably, your journal, our journal, has become the most authoritative source of truth in gynecologic cancer. And the beauty of it is not only is it a conduit for education, but it's an international conduit. And I appreciate your leadership and all of your staff. And I'm excited to talk to you about liquid or cell-free DNA.
Excellent. Well, thank you so much for those words. Let's get started. I want to get started by discussing why is ctDNA an important breakthrough in the management of patients with gynecologic cancers?
Yeah, and thank you for not limiting it to just cervical cancer. We're going to dive into this randomized phase 3 trial, which we know is CALLA. So cell-free DNA serves two distinct purposes that overlap. Let's talk about the first, because that's not what we're going to talk about, is for molecular profiling. So you can get a very good idea of whether or not, and again, this is nucleic acid DNA. You can also do RNA, but mostly DNA, of understanding the molecular signature. Now that's different than minimal residual disease MRD. I want to go back to the first indication. Let me give you an example. So we just got approval of avutametinib and defactinib in KRAS mutated low-grade serous ovarian cancer. And we're changing the landscape. But you got to have a KRAS mutation. Now you can draw the blood and see if that patient has a KRAS mutation. And then you're done. You don't have to wrestle the tissue away from the pathologist. It's okay if you're a pathologist, guys, sorry. But it's not a wrestling match, I apologize. You don't have to get the tissue from the pathologist. But it's not 100% sensitive. In other words, if the KRAS mutation is not in the cell-free DNA, then it still might be in the tumor, so you should do that. But it's a nice place to start, and it's been, and there's several vendors, and frankly, most of them are very specific, meaning they're generally right when it's positive, with minor deviations in sensitivity, meaning, well, if one vendor is positive, is the other vendor positive? Probably. Now back to MRD. MRD is a disease assessment. Is there cancer there? There is here a very large distinction in sensitivity. And it's very difficult for us as clinicians to figure out whether this MRD liquid cell-free DNA assay is better than another. And once a company is launched, then they're very reticent to change. They're like, well, we're good enough. So the newer companies, as a rule, but not a universal rule, are better. And then in MRD, there are two ways to do it. There are, well, let's just look for a P53 mutation, let's say in a high-grade serous ovarian cancer, that is not tumor-informed. Or again, the state of the science is to let's see what genes are actually in the tumor, and then look for those genes in the blood. Now that takes, you got to get the tissue as well as the blood. So the former is maybe not as sensitive and specific. The latter, and I'm not going to use any company names, I'm going to try. The latter is probably the state of the science. It's a little bit more technical, but it's also more tactical. So the study that we're going to talk about is not the former, the molecular profiling, although that's relevant and it's transforming. And I use low-grade serous ovarian cancer as an example. But what we're going to talk about here is cell-free DNA as a disease assessment. And every one of you on this call knows what a CA-125 is and uses it in ovarian cancer. And if the CA-125 is positive in that patient, particularly in the patient that had a positive test in the beginning, you know it's only a matter of time that you're going to find cancer. And a lot of that is relevant here, except
Excellent.
it's DNA.
Well, that's an excellent introduction to this topic. And specifically, of course, obviously, we want to start addressing and discussing this trial, the CALLA trial. For our audience that may not be familiar with the findings of the CALLA trial, what was the primary question and what did we end up learning from it?
So, I'd love to talk to my friends, you today, and I wish our audience here that you were part of the conversation in a live way. And I try to share with you the hard lessons that I've learned. In this particular setting, all of us know that immunotherapy is active in cervical cancer. As you know, first in 158, second line PD-L1 positive, ultimately in Keynote 826, and now A18. A18 adds pembrolizumab to chemotherapy and radiation. And A18 is a practice-changing, label-enabling study. Before that, we did CALLA, which was a very similar, not the same design of A18. Basically, it took locally advanced, unresectable, high-risk cervical cancer and randomized them to chemotherapy alone versus this time at PD-L1. And I happen to be one of those guys that thinks that there's a small difference between PD-L1 and PD-1s. It's a different conversation. PD-L1s still work, but if you sort of do an inferential analysis, let's say a BCC, atezolizumab, PD-L1 versus pembrolizumab, 826, if you line things up, they're just a little bit of a difference. Same with DuoE and GY018 and Ruby. Again, PD-L1, durvalumab, and PD-1. So in this particular, we used PD-L1. That's what we had. That was the first thing. Was not a GOG study, was not an NGOT study. Not sure that matters, but those are just factors. 770 patients, a big swing. Trying to add immunotherapy, continued during chemotherapy and radiation, and in maintenance. And it was durvalumab, and it was given every 4 weeks. We call that a cycle in this study. And so when we talk about testing for liquid DNA, it was an exploratory endpoint, and I'm very keen to not overinterpret exploratory endpoints. As you know, exploratory endpoints create hypotheses that they don't test them. So I'm not going to get too much into the weeds here, but we're going to talk conceptually. And the ctDNA was measured 3 times in the beginning, at the end of chemotherapy and radiation, which was 8 weeks, okay, because they gave me every 4, cycle 2, and then ultimately in cycle 6, which is about 3 months. So we had 3 endpoints, and why do we choose those endpoints? I don't know. That's just what we did. And here's the teaching point, is the reason, and the sponsor here, God bless him, for not just saying, well, it didn't meet its primary endpoint, we're going to move on. But the sponsor here is committed to scientific discovery. So this study cost money, and Professor Jyothi Mayodev, who's the first author, and I went to the sponsor, said, look, we'd really appreciate you giving some money to pay this lab to use an ultra-sensitive MRD test to see if it's better than imaging. Because remember, the patients were getting regular imaging on the clinical trial, highly, highly annotated and highly audited. So God bless the sponsor. I don't think I've said a company yet, but that shows a commitment to scientific discovery, and we as a treating community are grateful. I'm grateful.
Yeah. So now tell us about that exploratory analysis. What did you search out to do here? And just tell us a little bit about the study design.
Yeah, thank you. And I didn't know. It's interesting because you can actually find HPV DNA in the blood, and so I didn't know which was better. I didn't know if looking for, as you know, if you want to see if a patient's at risk for cervical cancer, check for the virus. Why don't you look for the virus in the blood? Because that's indicative. That was a nice try. That's what we call a miss or a strike if it's baseball season. And I was just in Taiwan. I think congratulations. I think they won the Little League World Series. Pretty cool. And our good friend Arthur is from Taiwan. Congratulations. But that's a miss. And it makes sense now because in cervical cancer, you don't necessarily clear the virus, you clear the cancer. But the cell-free DNA, tumor-informed, ultra-sensitive, was better than imaging. And it predicted cancer recurrence about 5 to 6 months earlier. And here's the cool thing. If it's negative 3 months after chemotherapy and radiation, the patient has a greater than 90% chance cure. And does that mean that you should add it to Keynote 18? Does that matter that you should say, oh, I'm going to, in the FDA indication, it's, sidewall, ureteral, bladder, and rectal mucosal involvement. I'm going to start the chemotherapy and radiation pembro. And then, like Monk taught us, 3 to 6 months later, I'm going to do a ultra sensitive cell-free DNA. And if it's negative, I'm going to stop. I don't know, but maybe. And again, that's a hypothesis that has to be tested because this is hypothesis generating. My approach is a little different. What I like to do is say, look, at 3 to 6 months, if the cell-free DNA is still positive, not only is that patient in trouble, but we should intensify. We should intensify the treatment. We should maybe add in that setting an antibody drug conjugate like a sacituzumab trimotecan or a tisotumab vedotin antibody drug conjugate. And as you sort of learn and study the studies that I'm involved with, ADCs are chemotherapy, and so they shouldn't be given for a long time. And in fact, in frontline endometrial cancer, we only give it in Trophus 33 for 6 months. And if the patient's in complete response, stop. So because we have to be very invested, not only in the sort of clinical aspects, oncologic aspects, PFS and OS, and also quality of life, but the best way to improve quality of life is not to treat the patient or to stop it because all these medications have side effects.
So now, Brad, I mean, you talked a little bit about some of the results and what do you see as like the key highlights that our audience should take away from this exploratory analysis?
Yeah, thank you. So first of all, I all of us on this, we really work hard to treat patients with cervical cancer. There was this time when we would do a lot of radiation in the aortic area. Some people still do, and that's okay, particularly in high common nodes that are positive. But now what we do is we say, oh, we're mostly going to focus on the pelvis. And then, we're going to do a PET at 3 months. And if you got aortic disease, then we can generally radiate it then. Most patients won't need it. The first teaching moment is that probably should be 6 months because it takes time to resolve the cancer. A lot of false positives there. I certainly wouldn't do a 3-month PET and say, oh, look at that, and then radiate the patient without a biopsy. And so when you look at sort of the standard metrics for a diagnostic test, the positive predictive value, okay, the positive predictive value, I mean, if it's positive, okay, 3 months, you got a 61% chance that you're right, okay? In other words, and that's pretty good. That means you're in trouble. But the negative predictive value was 83%. The negative predictive value should have been higher. And the reason it probably wasn't higher, because we should have done it at 6 months. That's the analogy that I was drawing to the PET scan. So if I was to study this moving forward, I would probably use a 6 month into my clinical practice when I see a high risk all locally advanced cervical cancer, high risk locally advanced cervical cancer. I generally ideally would do a 3 and a 6. And if there's a 3, I try not to get too worked up about it. And if I'm in an under-resourced situation, which many of my cervical cancer patients are, still having a very small practice in Arizona. And here, many of our patients are under-resourced for 6 months as an assessment. And this particular test that was utilized here can be obtained commercially. You can find it, just read the paper and track it. But this is an aha moment, because not only is it cervical cancer, and we use cell-free DNA more in ovarian, but because these patients were highly annotated, we knew exactly who they were, and they had PET CTs done on time. We had something to compare it to. So that's very exciting. And should it be used in all of our patients? I don't know. Do I use it? Yes, when I can. The company's been very generous. Should we study it more? Absolutely. And probably, we need, and that's why the first thing I said is international journal, international call, probably more of an opportunity internationally, because it's just difficult. It's difficult to do any research, period. But cervical cancer even takes it to a different level. And we got plenty of cervical cancer here in the US to study, but it's just tough.
Yeah. So now on to the questions from our fellows. The first question comes to us from Frederica Stroich, Heidelberg University Hospital in Germany. She asks, ctDNA is a short half-life, which makes it a valuable tool for treatment monitoring. Could you comment on the time points used for ctDNA measurements in this study? Are there additional time points that might be important to explore for clinical use in future studies?
There are, and I sort of alluded to it. I like 6 months, but again, you have to sort of be proactive. This is all I got. And if you look at the biomarker informed population, it's only a subset, because we had to get permission. We had to be able to have permission to ship the DNA to Northern California, where this test was run. But absolutely, we do need additional time points. And frankly, we just need additional studies. And by the way, Heidelberg is one of my favorite cities in the world. Next question.
That's great. Federico will be happy to hear that.
And so is Barcelona, which is where Natalia is from.
Brad, the next question comes from Barcelona.
I know.
Natalia Tejeda, she's asking, since persistent ctDNA post-treatment was strongly associated with relapse, could you clarify what additional tools were used at the time of sample collection to assess disease persistence, and how ctDNA compared to conventional imaging or clinical evaluation?
Yeah, so that's a great point, and I appreciate you answering that question. And that's why this paper was presented as an oral presentation at ASCO by Professor Maeda from San Diego, because this was part of clinical trial. Patients were compliant, and the imaging was paid for. So there was very little protocol violations, but that's what makes it, physical exam and CT imaging. Good question.
Excellent. This one comes from Helena Obermeyer in Sydney, Australia. And she's asking, were there any specific patient or tumor characteristics you noticed that were more common in patients who cleared ctDNA compared to those that did not?
It's a great question, and I didn't address it earlier. So just like a CA-125, right? If you have a patient, and it's just a piece of the puzzle, but if you're considering to do a primary debulking and the CA-125 is 600, it's just a piece of the puzzle. I kind of like it. But if the CA-125 is 5,000, I'm gonna give it a double take. Do I really want a piece of that? So ctDNA, same thing in the beginning. If the ctDNA was very high in the beginning, it's a bad thing. There are also histologic factors that predict recurrence, and you guys use that every day. So the first thing that I asked when I saw these data at actually the IJGC in Ireland, it's the first time I sat down with the team. I said, well, this is just telling me that the worst tumors do worse. And they're like, Oh, we didn't think of that.
Yeah.
And I said, well, now you got your work to do. And now what they showed was this is independent of histopathologic risk factors. So you see that patient with multiple lymph nodes and bladder and rectal or sidewall or hydro, you can still cure those patients with chemotherapy and radiation, and you know it. But you don't know who it is. And if you do a ctDNA after chemotherapy and radiation, you go, you'll see also smaller lesions. We've all seen patients with parametrial or paracervical soft tissue extension, and that patient, she should have been cured. What the heck? What happened? And so again, those patients also. So this is an independent, and how do you describe it? This is about the biology of the tumor, which again is sort of a dynamic biomarker that's exciting, and you can feel my energy. But this is a real step forward.
Yeah. Mariana Carvalho from Sao Paulo, Brazil. She asks, in cycle 6, day 1, there's a 13% lower detection rate in ctDNA. Do you think this reinforces the hypothesis that CALLA trial was negative due to a lower risk population in comparison to Keynote 818 population? Do you think other hypotheses such as PD-1, PD-L1 differences could explain the different results between these trials?
These are fellows. Okay. No, they're not, but it doesn't matter.
She'll be proud. She'll be proud that you said that.
So first of all, there was a treatment effect in CALLA with durvalumab, and the treatment effect, it wasn't the endpoint, got better with PD-L1. Now PD-L1, they use SP263 as the antibody, and they used a tumor area positivity score, or TAP, of greater than 20%. And the delta between patients that received durvalumab or not was even bigger when you utilized a detection method of ctDNA. So there was a treatment effect, and to her point, it just wasn't as great as pembrolizumab. So this idea that pembro is or PD-1s, it's not the agent, it's the class, is more effective than PD-L1s. That's my bias in an inferential cross-trial, I hate to use the word cross-trial comparison, but analysis, inferential, because it doesn't prove it. And I also think that the higher risk patients have more events. And so the number of aortic nodes in A18 was almost 4 times what it was in CALLA. So I think there are several reasons. Yes, it was a higher risk population in A18. Yes, it was a slightly better molecule. And you're gonna hear about this ovarian trial with pembrolizumab called B96 very soon. And B96 shows that pembrolizumab works in platinum-resistant recurrent ovarian cancer when added to weekly paclitaxel. And maybe we'll have this podcast. Nicoletta Colombo is the first author. She'd be better equipped. But you're going to ask, why was it positive when IO therapies in ovarian cancer historically have been negative? And just like with A18, it wasn't one thing, it's several things. But as you get to know the clinical trials that we all do together, we and it's not cheating, but we enrich the population. We enrich the population that maximizes the chance of technical success. And even though A18 was technically successful, the FDA did a post-mortem on it, and in their infinite wisdom, and the EMA agreed with it, that it should only be approved in those, rectal, bladder, mucosal sidewall hydronephrosis patients. And really the reason is because that higher risk patient, it was easier to show a difference. And I thought, just like when we designed PRIMA in the high risk population, that we would get an all-comer indication for A18. Mm-hmm. Again, Primus is high risk. We got an all-comer indication based on risk factors. The opposite happened with A18, and I've written about this. So I would have thought we would have even got a broader indication than A18. We didn't even get the indication that was studied in A18. So in Prima, it was larger, and in A18, it was more restricted. And so it's very difficult to predict. And in the world of transparency, and the FDA is an a U.S. agency governed by Congress, we need more transparency, because if we know the rules, then we can quite frankly compete more in the space. But what a great question, hard question. Yeah. And again, it's not the one thing. We'll talk about B96. It's not the one thing, it's the several things. And at 18, it wasn't just those few things, about those are two of the things, the risk and the agent, and there are other things.
Great. So now back to Helena Obermeyer in Sydney, Australia. It's about what we do every day. So she's asking, in your study, ctDNA detection for post-treatment surveillance preceded radiographic progression by a median of about 5.5 months. So how do you envision clinicians could leverage this lead time in your practice?
I don't know. These are harder questions. But again, I think the leverage is to study those patients. It's same thing with the C125. C125 is maybe closer to, you probably know better, Pedro, but about 3 months. If you got a C125 that's going up, and you do a PET CT which is negative, the challenge is that we can treat patients too soon, particularly with ovarian cancer. You know, we can also treat them too late. If you treat them too soon, you impair their quality of life. Treat them too late, you can't rescue them from a bowel obstruction. I don't know if that's true here, because but I don't know. I don't know the answer. It's a good question. We have to do more research.
So then now Luisa Prope from University Hospital Münster, Germany. She's asking, how did you address the various confounders that can impact your measurement of ctDNA? In your opinion, how high is the risk of false negative or false positive results?
Yeah, I don't know. And it's, again, this is hypothesis generating. Incidentally, I was on a train once, and I've learned German since, but I went to Münster and I got off the train. I'm like, wow, a beautiful, beautiful city. But I was supposed to go the other way to Dortmund. But that's the only time I've been to Münster. But it's I don't know. And I think this is what we do, and it's an appropriate question, is that we take a DuoE result with PARP and IO in endometrial cancer, and we start to say, well, what about the PMMR and all in Ruby? Well, what about the P53 mutated? Stop. You know, the study is what it is. It's important to discuss it. I don't know if we're really ready, though, to make treatment decisions. I think, and so, and I know that that's what we do. And I don't, and that's one of the first things I said. I'm not going to overanalyze this. So I can't answer.
Yeah, and you said something very important earlier. I mean, it's exploratory, hypothesis generating, not something that you take as for practice changing. So now this question comes from Rosano Marina from Milan. She says, your data showed that ctDNA, but not HPV DNA, was prognostic at baseline, despite near universal detection of both. Could this difference reflect inherent biological variances in tumor shedding of viral versus somatic DNA, or suggest that ctDNA better captures tumor burden and aggressiveness in locally advanced cervix cancer?
My next trip is to Milan for the Trophus 33 investigator meeting. I hope to see her there. And the answer is yes. Ding. Both points. Yes. It's more reflective of shedding. And yes, it's more reflective of biologic behavior. Thank you.
So again, another question from Rosanna. She's asking, although the CALLA trial did not show a statistical significant benefit of durvalumab in the overall population, ctDNA clearance appeared higher in the durvalumab arm, particularly in PD-L1 greater than 20% tumors. Do you think future immunotherapy trials should use ctDNA dynamics for stratification or response adaptive design?
Yes. these are really smart people. I mean, they must have got their highlighter out when they read the paper. And maybe this paper will within the U.S. in order to remain board certified, we have to read papers and get the highlighter on. If we don't get the questions right, then we don't get board certification. But that's a good question, and yes, they should. I think the challenge is for the positive studies. CALLA was negative. I think the better question is in A18, they collected all the ctDNA, even in Prima. We got cDNA specimens. But will the sponsor, allow us to analyze them? And I think that like the sponsor of CALLA, if we have a unified voice, it's not about selling medications. It's about helping people. We're in the people business. And so I get it that these are for-profit companies, but they also have, and I think that the individual members of the scientific community within the sponsors agree with this, but the senior leaders, I think we need to continue to remind them that at the end of the day, we're trying to help patients. So I hope to see cell-free DNA from Prima, a study that I've been involved with from the very beginning. And I hope to see ctDNA in A18.
Right. Brad, and by the way, I think you and I still use highlighters. I don't think anyone.
Stop that. I was on a call and I said, put my name in your Rolodex. And she says, my what? I said, in your iPhone. And she, oh, okay.
Yeah, I don't think any of our fellows are using the highlight. So
and the
Sophia
Rolodex
Bigardi,
and the Rolodex.
that's right. Sophia Bigardi from Padua University in Italy. She says, your study highlights that ctDNA detection after chemoradiotherapy could predict relapse in locally advanced cervix cancer before clinical progression by about 5 months. How do you envision incorporating ultra-sensitive ctDNA testing into standard follow-up protocols?
A good question. And within ovarian cancer, there is a vendor out there, at least within the U.S. And I know her question is not from the United States, but we can get for ovarian cancer. We can get monitoring, liquid DNA, tumor informed. And if you're listening in the U.S., you know who that is. I think we should try to get this paid for. So how do I utilize it? It's all about payment, unfortunately. I think the good news is what you're going to see. You remember when germline or somatic testing was thousands of dollars. It's now less and less expensive. So I think the utilization will be iterative based on the financial burden, and it's very likely to decrease. And these medicines are going to get cheaper too, because PARP inhibitors are going to go generic, and checkpoint inhibitors and go biosimilar, and obviously bevacizumab is already biosimilar.
Yeah. So, Brad, just a few more questions I have for you. I'm going to go to a question by Mariana Carvalho, also from Sao Paulo, and she's asking, if we had access to perform ctDNA in low and middle income countries, would you suggest that we use it outside of clinical trials?
Yes. Yeah. Yes. We just, and again, her question is very interesting because she talks about the macro, the country, but there's still I got a patient right here in Palm Beach I saw yesterday. She's in a very rich country, but that doesn't mean that she has funding. Okay. So I had to put her in the hospital so she could get her tumor biopsy. That's the only option. And it's not good utilization of our healthcare system, but the answer is yes. And I like the way they're thinking. And I used to be a very young man. Now I'm just a young man. Okay. And I empower the very young, even the very, very young, to do exactly what these smart people are suggesting. And it takes a team. It's iterative, one step at a time, brick by brick.
Excellent. So, Brad, I'm going to finish with one last question here that may be somewhat provocative, but I know if anyone can handle it, is you. The question is, are we at risk of overhyping ctDNA as a silver bullet surrogate marker for locally advanced cervical cancer simply because the therapeutic agent under study, particularly in the CALLA, durvalumab, did not deliver a broad benefit? In other words, Is ctDNA being used here to salvage a negative trial that rather than to truly guide patient care?
It's a good question. CALLA was a definitively negative study. And in fact, the only definitive studies are negative studies. In fact, positive studies, and I've already alluded to it at 18, they actually ask more questions than they answer. Okay. The hype, I'm a high energy guy. That's how I get up every morning, because I know that we're going to discover something meaningful like cell-free DNA that's going to give useful information to patients, and maybe even develop a medication and antibody drug conjugate. And so it's a complicated question. I think we have to be fair of what we're doing, but if we don't have, and hype, I use the word hope, and I get it that they both start with H, but I am hopeful. Now you can say, am I over hopeful, over optimistic? I don't think so, because I'm old enough to remember where all we had was carboplatin and paclitaxel. And that's not where we are today. And the beauty of the fellows that commented today, think of this. We talked about radiation. We talked about systemic therapy. We talked about biomarkers and clinical trial design. That's cool. So thank you, Pedro, for your leadership, and for I really appreciate you and your team and the journal.
Well, Brad, thank you so much for your time. And of course, obviously, as I mentioned before, always a pleasure speaking with you. Always learned so much. I feel like these podcasts could continue on and on for much longer, but I want to be respectful of your time. Again, as I mentioned before, really thank you for the contributions you have made to gynecologic oncology. Really have really left a mark and continue to do so in your work. So truly admirable. Thank you very much.
Thank you.